Sticking to the facts, from confusion to clarity in adhesive use. This is just a quick little snippet about adhesives that we use in vascular access. So let's start with this right here. Let's count the ways that this is wrong. Like, this is a terrible, terrible dressing. So this little snippet here is about adhesives. How is the adhesive working on this dressing? Anybody? It's not. It's not. There's so many things wrong with this. It looks to me like it's migrated out a little bit, so I don't really see any type of securement on this dressing or on this device. And there is two different CHG patches on that. What is the one on the top going over? Does anybody have any idea what that might be? Like, there is so much wrong with this. So I just wanted to start out with this to begin with. If anybody has seen one of my presentations, I did this pull study with dressings. And I set this whole thing up and pulled, I think it was 23 different scenarios of all kinds of different securement devices and dressings and combinations and adhesives that I applied to these things. And the thing that I found out through that pull test was the dressing is part of the securement. It's not just to cover. So for years, I just felt like, oh, it's just to cover it up. It's to keep it from getting an infection. But the fact of the matter is the securement devices that I pulled without the dressings on was about a third of the securement. So with the dressing and the securement, it was almost 2.5 times the force. So it is super, super important to keep the dressing on. It does two things. It helps to secure the dressing and stabilize, or it helps secure the catheter as well as stabilize the catheter, and then also it helps to prevent infection. So how much does it prevent? So this is a landmark study. If you have not seen this study, it's by Timsit, and this is where we realize how big a deal it is to keep your dressings on. Okay, what Timsit was looking at is infection. And as there's more dressing changes that occur, there's a higher risk of infection. And it's exponential. So the first dressing changes within a 7-day period, you've got this amount of risk. Dressing adherence is a single risk factor for bloodstream infections. And the more dressing you change, the more dressings you change, the higher the risk. People tell me what their policy is, but what do they actually do? It's very different. Because here is a study from Richardson that shows that 3/4 of the dressings don't even make it to 48 hours. Like, we say, oh, we change the dressings every 7 days in PRN. Well, what I think is you're going to change the dressing PRN and you hope it stays on for 7 days, because that's the reality. This is a study that shows that very thing. These dressings are not staying on for 7 days, and for us to kid ourselves that they are, we're not paying attention. We're absolutely not paying attention, and we're putting our patients at risk. Every time a new guideline comes out, every time a new recommendation comes out, a white paper, a consensus statement, there's new ideas, new terminology, and a lot of times it gets confusing. And then you have this standard, and this clinical guidelines, and this CDC recommendations, and sometimes they're in complete conflict with each other. And as policy writers, we're like, how are you even right? What does this mean? I'm so confused by the terminology and what they're saying, because sometimes they contradict each other. Well, this has happened again. The most recent publication out from the AVA organization was the standard of care for peripheral IVs catheters. And it was a consensus paper, and I want to bring about, I want to show you something in there that is really confusing to me. And so this is why I was motivated. So here, this is what happened. I'm just a simple man. I'm just a country boy. And honestly, I'm not the brightest bulb in the room, and so I got to make it so I can understand it. And this is why I have to put this effort into things, because I need to understand what is going on. And I did a poster and to help clarify some terminology. And that's what this whole presentation really is about. It's about medical liquid adhesives. So the terminology medical liquid adhesives is the umbrella. That's the umbrella term. And two medical liquid adhesives that we commonly use in vascular access is tissue adhesive and gum mastic. These are two very different, very different products. Tissue adhesives are designed to close skin. It's great. ... not a lot, right on the insertion site, seals it off. That's great. It protects your site from bacteria getting in. Gum mastic it makes sticky things stickier. And we use it on our dressings. They use it on other applications. Most of the hospitals have this. Is anybody using gum mastic? Yeah, we got quite a few. And if you're not, it's in your hospital for sure. But the way that we use that is we just trace around the border edge of the dressing. It keeps the dressing on. That's the power of the gum mastic. And I've got some studies over here that I'm gonna show you in just a few minutes. So basically, gum mastic does not equal tissue adhesive, and tissue adhesive does not use gum mastic. We do not want to put gum mastic over the insertion site to seal it off. Yes, it's an adhesive, but it's not designed to do that very thing. Here's my poster, and this is the statement in this document that drove me to clarify some terminology. Clinicians should consider the use of tissue adhesive and skin barrier film to improve dressing adherence and prevent dressing disruption and device dislodgement. This statement, I believe, is incorrect. I think it was probably an accident, an overlook of what this was supposed to say. This really should have said consider the use of medical liquid adhesives, because that's the umbrella term. This is, and I think that drawing this out and everybody understanding this will maybe help a little bit of the confusion, for sure.
One story I have about this, I had a privilege of being in Methodist Hospital in Gary, Indiana, and they used this product. I went in with the vascular access person to do a dressing change. I thought it was a 24-hour dressing change. It had been on for 7 days. Now, I've done thousands of dressing changes, and I could not believe that this dressing looked as good as it did. I literally thought it had been on for 24 hours. So it is amazing stuff. It works incredible, and I am definitely a believer. So I'm just going to trace this just like this.
The beauty of this is in 7 seconds, you can save a dressing for 7 days. And there's a ton of data that supports this. This is so important to understand. Here's a study that reflects 22% reduction in dressing failure. What does that mean? Less risk for infection for our patients. What does it also mean? Less dressing changes for the nurse. So you're improving your workflow by keeping the dressing on, without a doubt. Here's a risk of infection. This organization decreased their CLABSI rate by 90%. What did we say in the beginning? Keeping the dressing on. Dressing disruption is a single independent risk factor for CLABSI. Here's an example of an institution implementing a measure to keep on the dressings, and it absolutely worked for them. There's a lot of data out there that shows this type of stuff. Here we go again. In another organization to improve their intact dressings, they were looking at about a 60% intact dressing. They implemented gum mastic and it increased to 93%. So they had 55% improvement in intact dressings. This is awesome. And here's another one. So the time. This is whenever you look at the amount of time that we spend doing dressing changes, it may take us 7 more seconds to apply a gum mastic, but what is it going to do? It's going to prevent the disruption and changing of the dressing downstream. So overall, our time is reduced as clinicians that change the dressing when you keep the dressing on. And this is an example of where gum mastic did that very thing. So I bring this to you just to help clarify these terms. So if you see these terminologies and you misunderstand, what we don't want to happen, the reason why I'm here just sharing this is because you don't want to use the product the way it's in a way it's not intended. So be familiar with your IFU, follow your directions for use, and understand the chemicals that we're putting on our patient. If you need help doing this, and wonder if you're interested in using a product such as gum mastic to improve your dressings, I recommend that you reach out to the company and have them come in and help you gather some data. This is a data collection sheet. It is absolutely the best data collection sheet on dressing disruption. If I'm not mistaken, I think Dr. Marcia Ryder helped to create this as well. So we've got a lot of credibility, but do we have bandwidth? So if you're trying to make an improvement in your facility, you have to have data. And if you notice that the dressing changes are happening more frequently than you want, and you want to implement, gum mastic, reach out and have them come help you support an audit, because you're going to have to take data to your CNO, your manager, your director, your supply chain in order to be able to say, justify what this additional cost is. In reality, it's a cost savings because all of the dressings that you keep on versus falling off. So time and money and supplies. So I think that's all I have for you guys. Does anybody have any questions about adhesives that we apply to our devices? Anyone? Anyone? The question is that stuff still sticky when you go to change it? Well, yes it is, because it's still stuck. And so whenever you remove a dressing that has adhesive gum mastic on it, you need to remove it with the proper procedure. It's an adhesive remover. Adhesive remover, Detachol, as a matter of fact, they have their matching brother and sister, Mastisol and Detachol, and you use them together. What a lot of people will do, will put it in their dressing change kits. So you have on it, as vascular access, you put it on an insertion, then you go change the dressing, you've got a Detachol, and then you have a Mastisol, the Detachol to take it off, Mastisol to put it back on.